Relations. I'm Elizabeth McIntyre from Paris, France, but more importantly, a member of the EHA board, and I will be trying to keep time this morning. So without further ado, I'd like to open the session by presenting our president, Peter Sonneveld, from Erasmus University in Rotterdam, who's going to give you a very brief introduction before handing over to the next speaker. Thank you, Peter.
Thank you, Elizabeth. So is it on screen? Okay. So welcome to this press conference, and especially welcome to Sweden and the beautiful city of Stockholm, where we returned for this EHA meeting after, I think, has been 6 years. And actually it's the third time that EHA is here in Sweden. Today I will give you an overview of the new developments, what EHA is, what EHA wants, and where we want to go in the near future. So this is the 23rd Congress of EHA, and you know about the motto of EHA. It is about blood, and we want to, of course, do a lot for our patients. So our motto is towards a cure for all blood disorders. The European Hematology Association promotes excellence in patient care, research, and education in hematology. So we are not only working on research, we also work on different other topics. Education is a very important one. We want to educate our young people. And patient care. We want to improve the outcome, the treatment and the outcome of hematology diseases. In order to do this and get it done, we connect with hematologists worldwide. Here at the conference there's a very international audience of people with delegates from all over the world, from all continents, and in fact many from outside Europe. We want to advocate the interests of hematology and hematologists in the national and international levels, support the career development and support research as well. And of course, we want to harmonize the hematology education. And there are many examples of this, for example, the hematology passport and hematology exam and so on. I will come back to that later. This year, well, we have almost 5,000 regular members. There are many more delegates. So this year we have 11,368 Congress delegates as of June 12. In fact, it's more right now. From all over the world, as I said, and 6,000 unique users of the EHA Learning Center, which is an important source of information for hematologists. We are not alone in this world and not on our own. We work with many partner organizations in and outside Europe on all these areas of education, research, and patient care. The advocacy is, of course, a very important part. So we want support for hematology research, especially the EU funding programs. We want to assure that patients with blood disorders have access to treatment, which is a challenge in these days with all the new treatments and the cost of those. And of course, this is related to curbing the prices of innovative medicines. I mean, the cost is huge of those, and it's increasing all the time, leading to reduced access for many patients in many countries. Europe-wide definition of professional qualifications to get the level of education comparable across European countries, and improve the implementation of EU blood and blood components legislation. So we also support career development, and these programs are mainly established through providing research grants, both to physician scientists, so people who do, let's say, clinical research, and pure research grants for junior and advanced scientists who work in the lab and do all the research and development. Then we want to support the careers of young hematologists and also young basic scientists by 2 programs. One is CRTH. This is a clinical research training program in hematology. This started 2 years ago, and we have now completed 2 courses. Young hematologists working mainly in academic centers, where they get training during this course in performing clinical research and how to deal with all the stakeholders that are involved in doing a clinical trial. The other one is TRTH, Translational Research Training in Hematology. That's meant for people in the lab, and is in fact a collaborative program with the American Society of Hematology. This has been going on for a couple of years now, and people coming from the TRTH training are excellent qualified for doing a career in hematology research. We want to harmonize education by doing several things. One is to update the European hematology curriculum. Also to have an exam for hematologists. So after their training in hematology, they can perform the exam, and this is done here, has been done in here during just before the meeting here in Stockholm, and is a yearly exercise. Also, online, blended, and live learning opportunities are being provided by EHA, and we have a global outreach program to other countries across the world in order to provide them with the information, for example, coming from these meetings. The new journal of EHA, HemaSphere, was launched last year, and this is an open access, online, flexible and easy access journal that provides the latest scientific information and also news from the hematology community, updates from new information in other journals. And this is headed by Professor Andreas Engert from Germany and Professor Jan Kools from Belgium. So this journal is, let's say, a new journal, but it's increasing. It will be the major journal for EHA to prevent its news and information and scientific articles. What is new this year? We have started Topics in Focus program, focusing on high-impact issues in the medical field. And right now, there are a few of those, but in particular, immunotherapy, a new way to treat patients with hematology diseases like lymphoma, myeloma, leukemia. And one of those immunotherapies is CAR T cells. You have probably heard of it. These treatments are starting up now in Europe, and they will have a big impact both on the outcome of these diseases, but also financially, also in the way of operating procedures and the way we work in the large hospitals. The other one that I want to mention is hemoglobinopathies. This is like sickle cell disease or thalassemia. These are diseases of the red blood cell, congenital diseases, and approximately 7% of the population are born with these diseases, and it's increasing because of the refugees, immigrants. They come from the Middle East or Africa, where these diseases are present in a large number of the people. And since they are inherited diseases, they are let's say, a large problem in a way. It affects survival. Babies are born with these diseases. So we need to develop new treatments, and this is one of the reasons EHA has chosen hemoglobinopathies as one of the topics in focus. On the press briefing, we will, on Saturday, we will present these topics in depth. Okay, I would like to stop here. Please ask questions if you want, or afterwards.
I think in the interest of time, we'll take the 3 EHA questions together.
Okay,
so if we
good.
could go straight from your talk, Peter, thank you very much.
Thank you.
And it's my great pleasure to present Martina Muckenthaler, all of the committee members, the lucky committee members, get to be chef d'orchestre of the Congress, and this year it's Martina, who's been a very active EHA board member, and she's going to tell you all about the conference.
Thank you very much, Libby. It was the pleasure for me this year to put together the scientific program. I've done it with a very large committee behind me. It's the scientific program committee and the advisory board, and it took us a year to put together this Congress, having numerous face-to-face meetings, telephone conference, hundreds of emails have been exchanged so that we have what you see here at the Congress. And I would like to present you first some numbers and then some special events that we have this year on the Congress. So it's a record-breaking Congress. We have the highest numbers of registrations ever. You can see the nice increase in registrations over the years, and it seems to climb up and up, which is really nice for us to see because it shows that there is an immense interest in this Congress. Concomitantly, the number of abstracts that were submitted have gone up, and this is also very important because we have the invited speaker program, which of course assures part of the program, but it's very important for the physicians and for the scientists to really submit their work to the Congress. And we have hundreds of reviewers going through these abstracts, and they are looking at the quality and assigning it to the sessions. And again, also this year, the number of abstracts that were submitted increased. Some other numbers: we have over 400 invited faculty, more than 300 sessions we have composed. There are 35 satellites and 6 updates in hematology. We have an enormous meeting place here where scientists, companies, and different organizations get together to exchange information for the benefit of the patients. As Peter pointed out, we launched the EHA Topics in Focus program on immunotherapy and hemoglobinopathies. And the points were made clear. Immunotherapy is really an emerging therapy to combat cancer. So there is an enormous interest, and you will see many sessions in the Congress covering this topic. And hemoglobinopathies is the second focus topic due to the challenges that we are facing with the big migration coming into the Europe from regions where these diseases, with genetic inherited diseases, with these mutations in the globin gene are present. And well, we have doctors here who have not really seen these diseases very much before, and well, they need to be educated in order to treat these patients. We had the second European hematology exam, the second Young EHA research meeting. It's really a big aim of the EHA to bring in the young community, and we try to give them a stage wherever possible. And one of the components is this Young EHA research meeting, which happens a day before the Congress starts, and we already had the satellite day. This is back to the EHA Topics in Focus sessions. We are kicking these 2 topics off here at the Congress, and please join the sessions. I think it will be of very general interest to really listen to the speakers, because we are trying to cover the topics from multiple sides. What we also like to do at EHA is to acknowledge excellence, and this is both at the senior as well as on the junior level. And we are awarding prizes at very different levels. One is at the level of basic and translational research, and here we introduced last year the David Grimwade Award, which this year will be given during the opening ceremony to Peter Campbell. We will have the award for clinical research, which is the José Carreras Award, which will be awarded to Francesco Lococo. We also honor long-standing lifetime contributions to the advancement of hematology. This is called the John Bernard Lifetime Achievement Award, which will be received by Charlotte Niemeyer from Germany. For mentoring, outstanding contributions to hematology education, these awards will go to two personalities, Barbara Bain from Great Britain and Robin Foer from Italy. And as you also will see in the opening ceremony, there are various types of research awards that usually come with at least some money. The research grants with a significant amount of funding for research for young hematologists, and the best junior abstracts awards. And with this,
thank you very much. About an IMI European initiative that we've been lucky enough to obtain from the European Union, and it's called the Harmony Programme. So we have 5 minutes for that.
Good morning. First of all, I want to thank Livy for the introduction, and also the EHA for providing the possibility to share with you this this project that is an ongoing project in hematological malignancies named Harmony, in which EHA is actively participating. So the main goal of this project is our patients, and patients affected by hematological malignancies, that they are still have unmet needs, and they will need faster diagnosis, they will need personalized therapies, they will need the follow-up by using the best methodological approaches. What we think in Harmony is that big data, that the use of big data could help to improve the outcomes of the hematological malignancies of the patients suffering leukemia, lymphoma, and myeloma. And Harmony will address the patient needs and improve their outcomes. Which is Harmony, who we are? So Harmony is a project, is a large project under the umbrella of the Big Data for Better Outcomes. It's a project of IMI. IMI is the big initiative in public and private partnership in Europe, and is spending and is funding by 40 million euros for a period of 5 years. Now we are in the middle of the second year. And this is, so far, the large project in the IME Big Data for Better Outcomes initiative. I started 2 years, a couple of years ago. What we offer in Harmony, and we offer from now in Harmony, is a high-quality multidisciplinary source of big data platform, integrating the outcome measures and endpoint definitions in hematological malignancies, trying to provide tools to the clinicians and other healthcare system stakeholders to improve the decision-making. Harmony is a large project. It's a project involving all the players in the field. We are involving patient organizations, regulatory agencies, HTAs, policymakers, payers, and of course, hematologists coming from the different institutions and also working from the different working cooperative groups. In total, we are 53 members, and we also participate by the use of the, by the help of the pharma companies. This is a new, it's a different project, it's a different concept. It's a real platform providing different projects in the different hematological malignancies. And this is, if we want to stress some points regarding Harmony, this is the first IMA project on this Big Data for Better Outcomes initiative focusing in hematological malignancies. And we have to be proud as hematologists that this will be the first or the large program in Europe to apply the use of big data in health. And this is a project that this is a project that now is ongoing and now is starting to recruit data coming from all the different European countries, from all the different working cooperative groups. And this is for the reason this is an open project. And we open the project to all the institutions and also to all the stakeholders involved in the field, academia, industry, payers, and all the organizations that play an important role in the hematological malignancies, a diagnosis and also mainly for cure these hematological malignancies. It is the first and the last public-private partnership in hematology so far, and aim to include and to integrate, to generate a big data platform with high-quality data, including harmonization, data harmonization, and data analysis for all or almost all the hematological malignancies. And by using this platform, we will increase the application of the omic data in the clinical practice, and hopefully we will also speed up the drug development and to provide access pathways and facilitate the bench to the bedside process. Till now, there are several projects inside Harmony. We hope to develop a lot of projects inside this platform, this program. But now there are 5 running projects. 2 of them are the pilot projects. In AML, we want to analyze gene-gene interaction and the impact on the disease outcome. In CLL, we will explore a large-scale mutation analysis. In multiple myeloma, we will perform a revised international staging system for multiple myeloma. In acute promyelocytic leukemia, we will try to resolve the open issues in this disease that can be cured in 90% of the patients, but still remain a problem for the rest, for 10% of the patients. And there are other upcoming projects in pediatrics, ALL, and many other diseases. For those who want to know much more about Harmony Project, we have a booth on the exhibition area, and some more details will be provided tomorrow in the room K2 at 2:45. Thank you very much for your attention.
Deja, I hope I've pronounced your name correctly, from Nashville, Tennessee, who's going to update us on exciting data on an extension of CAR T therapy. We're used to hearing it in acute leukemia, and this is going to be an application in multiple myeloma, which I think is very exciting.
Thank you very much. It's Jesus Berdeja from Nashville, Tennessee. It's a very Spanish name, but I've lived in the United States since I was 9, so I call myself American now. So thank you for having me. This is a beautiful city, my first time. So I'm very pleased to present to you and happy that you selected this abstract. This is an update on BB2121, which is a promising therapy for heavily pretreated relapsed refractory multiple myeloma patients. These are my disclosures. I play with everybody, so I'm not partial to anyone, as you can see. I guess I got to keep it up there for a little bit. So multiple myeloma, as you all know, is the second most common blood cancer. And we've had great advances in myeloma over the last decade. And there's many approved therapies, and patient survival has improved. But unfortunately, despite all this, this remains an incurable disease. And more sobering is as patients use some of these therapies, the more common being the proteasome inhibitors and the immune modulating therapies. As patients become refractory to these and have had more than 3 prior therapies, their overall survival is only 8 months. B-cell maturation antigen belongs to the tumor necrosis factor receptor superfamily. It is nearly universally expressed in multiple myeloma cells and a few mature B cells, so it makes it a great target to be very specific to multiple myeloma. And BB2121 is a second-generation chimeric antigen receptor, or CAR, T cell that targets BCMA and induces a very rapid and sustained response in patients with heavily pretreated relapsed refractory myeloma. This is a busy slide, but it's actually relatively simple. On the top is what the patient actually goes through. So the patient is screened. Once they meet criteria, they are leukapheresed. This is how we collect their T cells. The T cells are then sent out for manufacturing of the BB2121 product. And this takes about 10 days, but then you have to have all the releases, make sure it's not infected, etc., and that can take another week or so. So it's usually about a 3 to 4 week process. Once the CAR Ts are made, the patient is then given what we call lymphodepleting chemotherapy, fludarabine Cytoxan, which is a low dose of chemotherapy to try and basically quell their own T cells so that they don't compete with the CAR T cells. The CAR Ts are then infused on day 0, and that is the only treatment the patient gets. They're in the hospital for observation of toxicities, and they then get released from the hospital, and their first assessment is at month 1. In the dose escalation, we had 21 patients that were treated with dose levels, as you see there, 50 million, 150, 450, and 800 million cells. And in the dose expansion, we had 22 patients, and we treated 10 patients at doses, 22 patients at doses between 150 and 450. These are the results. In terms of toxicities, there are 2 main toxicities that you worry about with CAR T cells. One is cytokine release syndrome, which is not too dissimilar from sepsis, and the other is neurotoxicity. And this has been described well in other CAR T programs. As you can see, we saw 63% of our patients had cytokine release syndrome and 33% had neurotoxicity, but most of these were grade 1 and 2, which are sort of the lower grade. So most people just had a fever. Some people had very transient low blood pressures that resolved with some fluids. And then only 5% and 2% of our patients had grade 3 or greater cytokine release syndrome neurotoxicity. Most of the patients had drop in their blood counts, as is expected. Most recovered by day 32. We had no grade 4 CRS events, and we had no fatal CRS or neurotoxicity events. These are the responses. So as you can see, there's an actually dose response curve. So at 50 times 10 to the 6, this is what we consider a subtherapeutic dose level. We had 1 transient response, and then at 150 times 10 to the 6, we saw an overall response rate of 57.1%, and patients who received more than 150 million CAR T cells had an overall response rate of 95.5%. These patients did not show you had a median prior therapy of 7 to 8 prior therapies, so very refractory, heavily pretreated patients. In terms of the tumor response, there's a question of whether you need a certain amount of BCMA expression to be able to respond to CAR T cells. And as you can see on the right panel, patients at the 450 million CAR T level, there appeared to be no difference in response, whether you were BCMA low or BCMA high. Our median progression-free survival in the 18 patients in the dose escalation, which are the ones who are further out, is 11.8 months. And in patients who achieve MRD negativity, and this is something, it's a much deeper level of response that we are now evaluating in patients in the frontline setting and early relapse. It's never been tried in this very heavily refractory population. So the fact that we can even reach it is impressive. So 16 patients were tested and 16 patients were MRD negative, and in those patients, the median progression-free survival is 17.7 months. So in conclusion, BB2121 and active doses of greater than 150 million CAR T cells induces deep and durable responses in heavily pretreated populations in the relapse refractory setting, myeloma. Median progression-free survival 11.8 months. 100% MRD negativity in the 16 evaluable patients with a median progression-free survival of 17.7 months. And I'll just put this in context in that the 2 last therapies that were approved in multiple myeloma in patients who had more than 3 prior therapies had median progression-free survivals for 3.9 months. So this is actually quite an impressive result if you put it in that context. To date, the safety profile of BB2121 has been very manageable at doses as high as 800 million CAR T cells, mostly grade 1-2 CRS events with infrequent tocilizumab and corticosteroid use, which are the drugs we use when these toxicities become more higher grade. We had 1 case of reversible grade 4 neurotoxicity, and we have not seen others in the drugs in the dose expansion. So the next steps are the BB2121 is now open in a global pivotal trial called KARMA. This trial is open for enrollment in North America and Europe. And then additional trials are planned in earlier lines of myeloma, including frontline therapy in high-risk patients.
Thank you very much. This presentation is now open for questions.
say. Sorry.
Hi. Neil Osterweil with Hematology News. 2 questions, please. One is, in lymphoma and leukemia, we've seen problems with loss of the antigen. Has that occurred with this particular CAR?
Yeah, so that's actually a very good question. So this is still being evaluated in the relapse patients, but thus far we've seen both. So there's been some patients who actually decrease their antigen load, but there's other patients that have just as much BCMA as before. So it's not clear that it's what we call an antigen escape.
Okay, and have you presented these data anywhere else?
No.
No. Okay, great, thank you.
Question over here.
Hello, yeah, Andrew McConaughey from PME. Just to clarify, could you explain how this differs from the data presented at ASCO?
I'm sorry, clarify what?
How this data differs from the data that was presented at ASCO?
It's very similar. Oh, is that what you asked?
Yes.
Oh, I'm sorry, I thought you meant the BCMA. So yes, this data was presented at ASCO.
Right. In that case, is there any other findings from this survey, this trial, that's going to inform the pivotal one? And the second question being, how do you see this treatment fitting into the treatment pathway in the long term?
I'm sorry, you're going to have to repeat the question. I didn't understand.
Sorry. The second part of it was, how do you see this treatment fitting into the multiple myeloma treatment pathway in future?
So, I mean, I think it's very early, but I think we've all been very pleased on how, even though this is a complicated treatment, in how manageable it is in terms of the toxicities. I think it's a very different treatment than we've seen in lymphoma and leukemia, at least for this particular product. I think it's also important to note that all CAR Ts are not created equal, and so you will see different toxicities with the different CAR T products, and I think that's important to keep in mind. I mean, these are basically different drugs that are being compared, and I think most of us think of CAR Ts as one particular therapy. I see this, I think it's a very nice treatment right now for our relapse refractory patients, and I think that's probably where it's going to first be used. But I think it probably holds a lot more promise in earlier treatment lines. I mean, we are seeing that even the patients that got MRD negativity, which in the frontline setting corresponds to a very prolonged survival. These patients are still relapsing, and so again, it's back to the characteristics of the patient population we're looking at. So I think the trials going earlier relapse and even in the frontline setting, very high-risk patients are going to be very provocative. But I would not be surprised if this is moved earlier in the course of the treatment of these patients. And I completely missed your first question. Sorry.
I think it was about how this might inform the pivotal
Oh,
trial.
so this is informed pivotal trial directly, actually. So as this continues to evolve and more data comes from this, it will likely affect that trial and perhaps even amend it. But it's at least for now, it's ongoing almost in parallel.
Thank you very much. I think we can now move on, and we're going to leave. Dijon, France, is going to present data on rationalization of BEACOPP usage. Thank you, Olivier.
Good morning, everybody. First, I would like to thank the organizer for giving me the opportunity to present today the results. I will present only summary of the study, and I can invite you to go to the session this morning at 11:30, room A2 for more extensive results. So the HL 2011 study was dedicated to advanced Hodgkin lymphoma. My disclosure. So the purpose of the study was to evaluate in a strategy of de-escalated treatment in patients with advanced Hodgkin lymphoma who reach metabolic response after 2 cycles of escalated BEACOPP to allow to obtain disease control similar to 6 cycles of escalated BEACOPP with a lower toxicity. And the study randomized 823 patients who were randomized between the experimental arm, testing the de-escalated strategy for patients with negative PET2, and after 2 escalated BEACOPP patients received 4 cycles of ABVD, and the dose intensity was maintained only for patients with positive PET2 who received 2 escalated BEACOPP. This experimental arm was compared to a standard arm with 6 escalated BEACOPP. That is the standard of treatment within the German Hodgkin study group, and the treatment which allow to obtain the better disease control published so far. So in the experimental arm, 84% of patients reach a negative PET2 and receive the de-escalated therapy. The disease control was similar in both arms, and progression-free survival was quite satisfactory, with a 5-year progression-free survival of higher than 85% in both arms, in 85.7% in the experimental arm. The overall survival was also similar in both arms, and the toxicity in the experimental arm, including serious adverse events, was significantly reduced. We reduced of about 40% the risk of serious adverse events. So, PET performed after 2 cycles of escalated BEACOPP can safely use to guide subsequent treatment and support the response-adapted strategy delivering 4 cycles of ABVD for patients with negative PET2, and we can reduce the treatment in most patients, 84% of patients, without impairing the disease control. This approach allows to significantly reduce the treatment-related toxicity in most patients, and the reduction of serious adverse events is about 40%, and provides similar patient outcome compared to standard escalated BEACOPP treatment. And we can consider that this approach is probably a new standard of treatment in this disease.
Thank you very much, Olivier. This presentation is now open to questions.
Hi, again, Neil Ostroyle with Hematology News. So, do you use brentuximab at all?
No.
You don't?
No, brentuximab is a result of Echelon-1 study, was previously presented at the last ASH meeting and published in the New England Journal of Medicine. And if we compare, it's always difficult to compare, cross-comparison between studies, but the results with AVD, brentuximab vedotin, are lower than our results. So, yes. So it's in terms of progression-free survival, and the population between the 2 studies were not strictly similar, because we enrolled patients with also NRBOR stage 2B with risk factors, while in the Echelon-1 studies there was only stage 3 and 4. But in our study, 88% of patients are NRBOR stage 3 and 4. But we observed that the outcome of patients with NRBOR stage 2B at the same outcome that patients with stage 3, 4. So it's not exactly the same population. In the Echelon-1 study, there was also a small subset of patients with more than 60-year-olds, and in our study, only patients under 60 years old were included. So it's quite difficult to compare, but the progression-free survival is lower in the with EVD etc. compared to our results with the experimental arm. And another point important that it's the toxicity. It's higher with EVD etc. compared to the our experimental arm is HL2